this lecture, we'll be discussing the management of labor. I'm Dr. Allen Olubukola, a senior registrar in the Department of Obstetrics and Gynecology, Obafemi Awolowo University, Ile-Ife. By the end of this lecture, I expect that you should be able to define labor, you should understand the physiology and the mechanisms of labor, you should be able to discuss the stages of labor and the appropriate management of a woman undergoing labor. Approximately 140 million births occur globally every year, and labor and delivery mark a significant milestone in every woman's life and her family, and is an experience that they are unlikely to ever forget. And it is the goal of every healthcare provider to make this experience memorable and worthwhile for a woman and her family. Labor is defined as a physiologic process during which the fetus, membranes, and placenta are expelled through the birth canal after the age of viability. And this process is characterized by the onset of rhythmic, painful uterine contractions, leading to progressive cervical dilatation and effacement, culminating in the descent of representing parts and eventual delivery of the fetus and membranes. There is also a concept of normal labor, and this is described is a retrospective diagnosis. That means it can only be taken after the whole labor process has occurred. And this is described as the spontaneous onset of uterine contractions occurring at term in a pregnancy with a singleton fetus in vertex presentation, and during which there was no operative intervention of any kind, eventually leading to delivery of a healthy baby and placenta to a satisfied mother. Most vaginal births occur in pregnant women in which there was no previously identified risk before the onset of labor, either in them or in their unborn babies. However, in certain situations, some complications may arise during labor, and this puts these women and their babies at risk of serious morbidity and mortality. Over a third of maternal deaths have been found to be attributed directly to complications that occur during labor, childbirth, or in the immediate puerperium. And this also applies to stillbirths, as approximately half of them have been found to arise from complications during labor and childbirth. Therefore, it is imperative to note that improving the quality of care around the time of birth is one of the most impactful strategies for reducing childbirths, maternal and newborn deaths, as compared to the strategies that are undertaken in the antenatal or in the postpartum period. So we'll this way describe the physiology of labor. The exact physiology of labor, that is what directly triggers the onset of labor, is still yet unknown. However, there are different theories that have been proposed for the onset of labor and the processes that occur during labor in order to help a woman attain vaginal delivery. There are certain hormonal factors that have been described. There is the progesterone withdrawal theory. It is important to note that progesterone is one of the important hormones that are found in a pregnant woman, and progesterone has the effect of uterine quiescence. That means it helps the uterus to stay quiescent during the whole process of pregnancy, and then reduces uterine contractions. It's however been noted that towards term and prior to the onset of labor, there is a functional withdrawal of progesterone. That means that the effective concentration of progesterone in the maternal blood does not actually reduce, but the efficacy of progesterone on its receptors tends to reduce, and this subsequently leads to increase in the propensity of the myometrial fibers to contract, and this also contributes to the onset of labor and helps the process of labor along. The estrogen theory has also been proposed, and it's found that there is increased free estrogen during the last trimester and during the process of labor. And estrogen helps to increase the excitability of the uterine myometrial fibers, and it also helps to stimulate prostaglandin synthesis, and prostaglandins are very important in the physiology of labor. So talking about the prostaglandins now, prostaglandin E2 and F2 alpha have been found to be powerful stimulators of uterine contraction, and these are found to be at increased levels in the maternal and fetal blood, as well as in the amniotic fluid towards the end of pregnancy and during labor. And these have also been found to be secreted by the destructure. So stimulation or secretion of these prostaglandins help the process of cervical ripening to start and then to progress. And these also prostaglandins also help to stimulate uterine contractions, particularly prostaglandin F2 alpha. Then oxytocin is also very important during the process of labor. And although some degree of oxytocin is present in the maternal serum at all times, towards the end of pregnancy and in the process of labor, the secretion of oxytocin is also increased from the posterior pituitary gland, And then there's the oxytocin enzyme, which breaks down oxytocin as it is produced. But the secretion of this enzyme from the placenta is also found to be decreased near term, and this helps to increase the concentration of oxytocin within the maternal serum. Then fetal cortisol has also been found to be very important in the onset of labor, and it's found that prior to the onset of labor, there is increased cortisol production from the fetal adrenal glands, and this helps to influence the onset of labor. So some other mechanical factors have also been discussed, and this include uterine distension theory. That means that as pregnancy progresses, the uterus continues to distend because of the growth of the fetus and also increase in amniotic fluid. So once the uterus is distended to a certain limit, it starts to contract to evacuate its contents. And this may also may be corroborated by the increased incidence of preterm births that's found in women who have multiple gestation. Because the distension of the uterus is more, the onset of labor tends to occur earlier than in women who have singleton pregnancies. The stretch of the lower uterine segment by the presenting part near term has also been attributed to the onset of labor, as this distension helps to stimulate the onset of uterine contractions. So this diagram just depicts the states of uterine quiescence during the antenatal period. So the uterus is maintained in a state of quiescence because the amount of oxytocin reduced from the posterior pituitary gland is reduced. Also, fetal cortisol secretion from the fetal adrenal gland is also reduced. And there is increased progesterone secretion from the placenta, which helps to maintain the uterus in its quiescent state. However, once at the onset of labor, there is increased secretion of oxytocin from the maternal posterior pituitary gland. On the part of the fetus, there is increased cortisol production from the fetus, and this cortisol plays many roles. It also helps to stimulate the fetal organs for extrauterine life, as this cortisol secreted also helps to hasten fetal lung maturation in preparation for extrauterine life. Then there is also reduction in this progesterone, as discussed earlier, the functionality of progesterone on the mammary glands. There is increase in oxytocin receptors on the uterus, increase in gap junctions, which help to facilitate uterine contractions, also increase in progesterone receptors. So all these factors together help the onset of progressive cervical ripening and the onset of uterine contractions, which eventually culminates in labor. The mechanism of labor is briefly described as a series of adaptational changes in the attitude and the position of the fetus as it passes through the birth canal. And for a woman to be able to achieve vaginal delivery, there must be 3 participants. These are described as the 3 Ps, known as the powers, the passenger, and the passage. The powers refer to the uterine contractions, as there must be adequate uterine contractions. The maternal pelvis must be capacious and adequate in order to allow the fetus to pass through. And then the passenger, which is the fetus, must also be on average size. So there are cardinal movements during the mechanism of labor, and this diagram just elicits this. The important movements include descent, and descent occurs throughout the process of labor, from engagement to the delivery of the baby. And so engagement is said to occur when the widest diameter of the fetal presenting parts has passed through the pelvic inlets, and is the first stage during the mechanism of labor. So once the fetal head has engaged, and the fetal head tends to engage in either the transverse or the oblique diameter, because this is the widest part of the pelvic inlet, and this allows room for the fetal presenting parts to descend well into the pelvis. So once this engagement has occurred, there is also progressive descent, as mentioned earlier. So as the fetal head or the fetal presenting part reaches the pelvic floor, this encourages the fetal head to flex. So there is increased flexion at the fetal neck, and this also helps to flex the fetal head well, such that the presenting diameter is reduced. And in vertex presentation, it should be a submental occipital-begmatic diameter, which is 9.5 centimeters. And this allows, with good flexion, there should be appropriate vaginal delivery, provided all the other factors are in place. So once there is good flexion, the part that will hit the maternal pelvic floor first, it tends to be the fetal occiput. And it's because of the shape of the slope of the pelvic floor muscles, anything that hits the pelvic floor first is rotated anteriorly beneath the pubic symphysis. So in a fetus with a well-flexed head, the occiput reaches the pelvic floor first, and then there's rotation of this occiput anteriorly underneath the pubic symphysis, and this is known as internal rotation. So following internal rotation, there is progressive descent as well with good uterine contractions, and then the fetal head is subsequently delivered by extension as depicted here. So during the process of internal rotation, because the fetal shoulders would also have eventually, during the process of internal rotation, there is some degree of torsion between the fetal head and the fetal shoulders because of that anterior rotation to underneath the pubic symphysis. So after the fetal head is delivered, the fetal head needs to adjust back to align itself into the proper position in relation to the fetal shoulders. And this movement is termed as restitution. So it's a movement of 1/8 degree of a circle in the direction facing the opposite thigh from which the fetal head engaged. And this is termed as restitution. So at this point, the fetal head has delivered, and there still needs to be delivery of the fetal shoulders and the rest of the fetal body. So the fetal shoulders would also go through the same process in which the fetal head went, and such that the fetal shoulders would also need to engage, and then the anterior shoulder would also rotate, undergo internal rotation under the pubic symphysis before eventual delivery can take place. So the internal rotation of the fetal shoulders is obvious externally as external rotation of the fetal head, and this is the last point in the mechanism of labor. So after the internal rotation of the fetal shoulders has occurred, externally noted by external rotation of the fetal head, then delivery of the anterior and then the posterior shoulder will occur, and this will be followed by delivery of the baby. So at this point, I'll just briefly describe the stages of labor. The labor can be defined traditionally into 3 stages, the first, second, and third stage, and there's also a fourth stage that has been added as an addendum. So the first stage of labor is basically the period from the onset of labor to full cervical dilatation, and the timing can be variable. The first stage of labor is also divided into 2, the latent phase and then the active phase. The latent phase is the period between when the cervix is closed and then cervical dilatation of 3 centimeters, and this is also associated with uterine contractions, as these contractions will lead to progressive cervical dilatation and effacement. So once a woman has reached 4 centimeters cervical dilatation, this is termed active phase, and the active phase is the period between 4 centimeters and 10 centimeters of cervical dilatation. So the second stage of labor begins at the point in which there is full cervical dilatation, and then it ends with the delivery of the fetus. So it's the period between full cervical dilatation and eventual delivery of the fetus. So then we have the third stage of labor, and the third stage of labor begins after delivery of fetus, and it ends with expulsion of the placenta. So it's the time in which the fetus has been delivered and then expulsion of the placenta and membranes. So this is the third stage of labor. The fourth stage of labor, which has been added, is known as the state of early recovery, and this is just described as the first 1 to 2 hours following delivery of the placenta. And this is added because this should be a point of high vigilance in which the mother should be examined and monitored properly in order to identify and promptly manage any complications that could arise within this period. So the concept of the active management of labor, it involves a package of interventions that are offered to a woman in labor traditionally. And the active management of labor is basically defined as a strategic approach to the management of a woman that is already established in the active phase of labor. And this is aimed at preventing, the whole purpose of this is to prevent prolonged labor, and is based on the anticipation of cervical dilatation of at least 1 centimeter per hour as the basis for safe delivery of a healthy baby to a healthy mother. And these are the components of the active management of labor, which have been used traditionally in management of women in labor. They include early diagnosis of labor. So this means that once a woman presents with complaints of labor pains, the woman should be assessed thoroughly and a diagnosis of labor should be made. If the woman is in labor, then you need to stratify, is she in the first stage of labor? What stage of labor is she in? If she's in the first stage, is she in latent phase, is she in active phase? And this will help to determine what mode of management this woman will need and receive. Then there's artificial rupture of membranes, which is also known as amniotomy. And artificial rupture of membranes was recommended for any woman that's already established in the active phase of labor. And this was with the aim to encourage or to hasten eventual vaginal delivery. Then there's the use of WHO Partograph in labor. Partographic monitoring is one of the important components of the management of labor as well, and this also helps to diagnose any complications in labor, such as slow progress in labor or any labor dystocia, and if this is picked on time, it can be addressed, and this helps to prevent complications such as prolonged obstructed labor in women. Then adequate analgesia must be ensured for all women in labor. The gold standard for analgesia is epidural analgesia, and this should be offered to all women in labor. Then judicious use of oxytocin is also an important component in the management of women in labor, as adequate contractions, as earlier discussed, are important in helping the woman to achieve labor. Also helps to prevent delay in labor. Then companionship is also encouraged in labor. A woman is encouraged to have a companion with her through the process of labor. This helps to improve her experience in labor, and may also help her need for analgesia in labor. So these are the components of the active management of labor. So, however, recently there have been re-evaluations of some of the interventions that are offered to women in labor. And the World Health Organization proposed a new approach to management of women in labor, and this is just basically described as having as a positive childbirth experience. And this means that this is described as one that fulfills or exceeds a woman's personal and sociocultural beliefs and expectations, including giving birth to a healthy baby in a clinically and psychologically safe environment with continuity of practical and emotional support from a birth companion and kind, technically competent clinical staff. So this is a schematic representation of the WHO intrapartum care model, and talks about different components. Starting from respectful labor and childbirth care, every woman in labor is expected to have respectful maternity care. She's entitled to respectful care and dignity during the process of labor. She should also have emotional support from a companion of choice. There should be effective communication by staff regarding any intervention that's going to be taken in labor. Whatever is going to be done for her should be appropriately communicated to her. Then pain relief strategies, the importance cannot be overemphasized, as this helps to improve woman's experience in labor. Then regular monitoring of labor, documentation of events, audits and feedback, both between the staff that are offering the care and the patient and her family receiving the care. Oral fluid and food intake is also encouraged in labor now, unlike before where fluid and oral intake restriction was advocated for women in labor. It's encouraged now that women in labor can be allowed to take fluids and also fluids as much as they can tolerate. Then mobility in labor is also encouraged, and women are encouraged to choose any birth position of choice, and they should be supported in their decisions. And then there should be a pre-established referral plan if the woman is in labor in a place in which she needs supervised care or expert care. There should be a plan, appropriate plan for referral for this patient before the onset of any complication, and there must be appropriate continuity of care. In the event of any referral, then there should be appropriate handing over of all the interventions that have been taken on in labor in order to ensure appropriate continuity of care. So we'll briefly discuss some of the things that have been challenged in the management of labor. Traditionally, once a woman comes in labor, a woman is admitted into the labor ward, even if she's in latent phase or even when labor is not fully established. And this has just been to monitor these women during the process of labor. However, recent observational studies have shown that for women who are admitted in the latent phase of labor, their labor tends to be associated with more arrests of labor and cesarean births in the active phase. It's also been found to be associated with a greater use of oxytocin, intrauterine pressure catheters for monitoring, and antibiotics for intrapartum fever. However, they were unable to appropriately determine whether these outcomes reflected interventions that were associated with the longer exposure to the hospital environment, or if these women had an intrinsic propensity for dysfunctional labor. For women, it's proposed now that women who present in a latent phase of labor, depending on the environment in which they are and the facilities are available in whatever hospital the woman presents in, a decision can be made on whether or not to admit her or whether she can be allowed to go home and present at intervals for evaluation, and then she would ultimately be admitted into the labor ward. So for these women in whom the decision has been made for them not to be admitted into the labor ward, a process of shared decision making is recommended between the woman and a healthcare provider. and an agreed upon time for reassessment should be determined at its timing of contact. Care of women in latent phase of labor may be enhanced by having a separate unit for these women where they can rest and can be offered support techniques before admission into the labor ward. However, admission may be necessary for some reasons, which include pain management and maternal fatigue, and when this is necessary, they should be offered appropriate care. So some techniques that can be offered to these women include education and support, oral rehydration. They could be encouraged to assume positions of comfort, and then some other non-pharmacological pain management techniques may be beneficial to these women. So regarding the first stage of labor, the definition of the first stage of labor is also being challenged, or has also been challenged recently. And this has been endorsed by the World Health Organization and the American College for Obstetricians and Gynecologists. So it's now proposed that the latent phase of labor should be defined as the period between when the cervical os is closed and the period of when the cervical dilatation is 4 centimeters, as opposed to 3 centimeters that's been used previously. And while the active phase of labor suggested to start from 5 centimeters and above. And this is based on several studies that have been done. A study that was done by Oladapo et al. In 2017 assessed the mean time between the onset of labor and eventual delivery, and also evaluated cervical dilatation patterns. And it was found that in nulliparous women, the median time for cervical dilatation to advance by 1 centimeter was longer than 1 hour before 5 centimeter dilatation. And from 5 centimeters and above, the median dilatation rate became 1.09 centimeters per hour. Then likewise, the similar finding was also noted in multiparous women, in which the median dilatation time before 5 centimeters dilatation was also more than 1 hour. However, this increased after 5 centimeters dilatation, in which the median rate became 1.49 centimeters per hour. So it's proposed that application of this new 5 centimeter dilatation threshold as a benchmark for the onset of the active phase of labor has the potential to reduce interventions to accelerate labor and birth, such as the use of oxytocin for augmentation of labor and offering these women cesarean section. This might, however, increase the cost of healthcare in terms of training and of healthcare providers and the reviewing of admission policies, as well as reorganization of the labor wards. However, this may be more beneficial to women in labor on a long-term basis. A standard duration of the latent phase of labor has still not been established, and it can vary widely from one woman to another. So as such, the diagnosis of a prolonged latent phase of labor is no longer encouraged as such, because the latent phase has been described to be the prodromal phase before the onset of labor, and the timing has not really been appropriately established. So women may be allowed to continue in latent phase of labor, provided there is no imminent danger to either the mother and the fetus, and all parameters that are being monitored remain stable. On average, it's said that first stage of labors may last an average of 8 hours, but however are unlikely to last over 18 hours, while in multiparous women, labor is unlikely to last over 12 hours. However, 12 hours, the timing of 12 hours still remains the benchmark for a diagnosis of prolonged labor. So a woman is said to have a prolonged labor when she has been in active phase of labor longer than 12 hours, and this helps to prevent complications such as prolonged obstructed labor. So in monitoring the progress of women in the first stage of labor, as discussed earlier, the cervical dilatation rate threshold of 1 centimeter per hour during the active phase has always been used, as depicted in the WHO Partograph. However, it's now been noted, as found from the study earlier discussed, that this threshold may be unrealistically fast for some women in labor, and as such is no longer recommended for identification of normal progress in labor, as some women who progress in labor less than 1 centimeter per hour may still be able to achieve vaginal delivery, provided no intervention had been offered. So in a woman who is being monitored in labor, if delay in the first stage of labor is suspected, then the following should be taken into account. Is this woman a nulliparous patient, or is she multiparous? Multiparous women tend to have slower labors, as has been elicited earlier. You assess the cervical dilatation and then the rate of change of this cervical dilatation. We want to assess her uterine contractions. Is she having adequate contractions, or will she need augmentation of labor? We want to assess the station and the position of the presenting parts. Has there been progressive descent, or has there been no descent despite adequate contractions? The position would also help to determine what kind of management this woman should be offered. If there is malposition, then this could be a pointer to a possible dysfunctional labor, and appropriate intervention can be offered tailored towards that. Then, of course, the woman's emotional, psychological, and physical needs should also be addressed, as this may also help in the progress of labor and help the woman to maintain a positive attitude during the process of labor and childbirth. So before any intervention is offered, then cephalopelvic disproportion must be excluded, and this can be done by assessing progressive descent, as said. We also want to note the presence of any caput or progressive caputs and molding in the fetus. So before delay in labor, in progress of labor can be diagnosed, as opposed to a cervical dilatation rate of less than 1 centimeter per hour. Now, with cervical dilatation rates of less than 2 centimeters in 4 hours is encouraged, which is essentially a dilatation rate of 0.5 centimeter per hour. So a woman must be assessed over 4 hours, and then if there's a progress in labor of less than 2 centimeters in 4 hours, then one can diagnose delay in labor. So at this point, when delay has been diagnosed, and if a woman still has intact membranes, then amniotomy should be offered to this woman. And then this can help to stimulate uterine contractions because of the endogenous release of prostaglandins, and this may help hasten the progress of labor. So after amniotomy is done, a repeat vaginal examination can be done 2 hours later in order to assess if there has been any progress in the labor. However, if this woman has already had a spontaneous rupture of membranes, or if she had artificial rupture of membranes, and at the 2-hour review following this, the progress of labor is still unsatisfactory, in the absence of any signs that may suggest cephalopelvic disproportion, then this woman can then be offered augmentation of labor using oxytocin. However, these women should be counseled that oxytocin may help to bring forward the time of birth, but will not influence the mode of birth or other outcomes eventually. So as such, if she will be able to achieve vaginal delivery, oxytocin will help to shorten the time to vaginal delivery, but will not change the outcome. So after oxytocin augmentation has been commenced, a repeat vaginal examination should be offered 4 hours after this, and then the process of labor should also be assessed using the same criteria, so that if cervical dilatation has increased by less than 2 centimeters after 4 hours, then one needs to review this woman appropriately in order to assess for the presence of cephalopelvic disproportion or a malposition, and possibly offer this woman cesarean section if needed. However, if the progress of cervical dilatation has increased by 2 centimeters or more, then this woman can be monitored as before, with under continued oxytocin augmentation of labor, and then 4-hourly vaginal examinations can be recommenced along with other modalities of monitoring. So regarding the monitoring of women in labor, the routine use of an admission cardiotocograph is not recommended for assessment of fetal well-being for healthy women who have been described as low risk when they present in spontaneous labor. So for monitoring of these women in labor, intermittent auscultation using a penile fetal stethoscope or using a Doppler ultrasound device is recommended for assessment of fetal well-being on admission in labor. Also, during the continuous monitoring or intermittent monitoring of these women throughout the process of labor, continuous cardiotocography is also not recommended for assessment of fetal well-being in women who have been described as low risk and who are undergoing spontaneous labor. So these women would also do well with intermittent auscultation of the fetal heart rate using either a handheld Doppler or using a penile fetal stethoscope. And for the intermittent auscultation, this should be performed every 15 to 30 minutes within the active phase of labor, but in the second stage of labor, this should be done every 5 minutes. So intermittent auscultation, at each point of auscultation, this should last for at least 1 minute. And if any abnormality is picked at any time, then this should be prolonged to cover at least 3 uterine contractions. So the auscultation should be done during a uterine contraction, and this should be continued for at least 30 seconds after the contraction. So this will help to assess the fetal heart rate holistically, and if there are any decelerations in response to contractions, then this can also be picked during the period of assessments after the uterine contraction. So this was a Cochrane review that was done to assess the benefits of cardiotogography versus intermittent auscultation on admission in low-risk women. And it was found that cardiotogography and admission was associated with an increase in cesarean section rates by 20%. However, there was little or no difference to the rate of low Apgar scores or development of hypoxic ischemic encephalopathy, neonatal seizures, or perinatal mortality in these delivered babies. Regarding digital vaginal examination for monitoring of these women in labor, digital vaginal examination is recommended at intervals of 4 hours for routine assessments of low-risk women during the first stage of labor. Before performing a vaginal examination for any woman, the procedure must be explained to the woman, and appropriate consent must be obtained. And this examination should also be done in the presence of a chaperone. It's important to ensure this woman's privacy, her dignity and comfort at all times during every vaginal examination. And the lubrication of fingers before vaginal examination must always be done, as this would also help to reduce discomfort in these women and help the examination easier. There is currently no direct evidence on the most appropriate frequency of vaginal examinations to prevent infectious morbidity in the mother and the baby. However, 4-hourly vaginal examinations are recommended as a good practice point, and this has been done with no adverse effects. Vaginal examinations at more frequent intervals may, however, be warranted depending on the condition of the mother or the baby, such that if there are any complications or any indication for a repeat vaginal examination, then this can be offered to the woman at this time. Multiple vaginal examinations of the same woman by multiple caregivers at different times must be avoided, so that if one person examines this woman at a particular point in time, then that should be taken as a vaginal examination for that time. Repeat vaginal examination to confirm findings or for the purpose of training of either students or student midwives is discouraged. So regarding an analgesia for women in labor, epidural analgesia remains the gold standard for management of pain in women in labor, and has been found to be a proven method for relieving pain related to surgery, including abdominal surgery, and also in labor. And it also has the advantage of a woman who has been on epidural analgesia in labor who might require an operative intervention such as assisted vaginal delivery or cesarean section may not need appropriate additional analgesia other than topping up of this epidural. And epidural analgesia is recommended for healthy pregnant women requesting pain relief in labor, depending on our preferences. In situations in which the epidural analgesia is unavailable, either due to requisite skill or in which the woman does not want epidural analgesia, other options for pain management in labor include the use of parenteral opioids. And commonly used opioids include fentanyl, diamorphine, and pethidine. Pentazocine has also been used depending on a woman's preferences. This Cochrane review also discusses or assesses the use of epidural versus non-epidural for analgesia for pain management in labor. And it was found that the use of epidural analgesia reduces pain scores in women during labor compared to parenteral opioid use. And women who receive epidural are more likely than those who receive opioid to rate pain relief as either excellent or good. However, there was little or no difference in Apgar scores less than 7 at 5 minutes. And then the number of babies who were found to be acidotic at delivery were probably fewer in those women who used epidural analgesia than those who had opioid analgesia. This study also looks at, compares different parenteral opioids that are available for use in labor. And intravenous pethidine was also found to reduce pain scores for women in labor. Intramuscular pentazocine were found to have conflicting results. In some women, they made little difference in pain scores. In some women, they made no difference in pain scores as compared to placebo. And this may be attributed to the mechanism of action of pentazocine, which has both mixed antagonist and agonist effects on opioid receptors in women. However, overall findings indicate that parenteral opioids provided some pain relief and moderate satisfaction with analgesia in labor, but were also associated with maternal nausea, vomiting, and drowsiness. And this may be some of the complications that may be seen in women who are on parenteral opioids during labor. However, it can be offered to women after discussion, and if they prefer this, they can still be offered to them in order to provide analgesia. However, parenteral opioids must be used in caution during the late stage of labor, as may be associated with neonatal depression if administered too close to the timing of delivery. There is, however, insufficient evidence to assess which opioid drug provided the best pain relief and which had the least adverse effects. So all of these discussed types of opioids may still be offered in women, depending on her preferences, on what is locally available in the center in which the woman is undergoing delivery. Okay. Another option for analgesia in labor includes inhalational analgesia, such as Entonox, and this contains 50% of oxygen and 50% of nitrous oxide, and is also known as gas and air. Entonox can also be used for analgesia for women in labor, and it can be administered as a patient-controlled analgesia. However, some of the side effects include nausea and lightheadedness. There are some non-pharmacological methods of analgesia in labor, and these include techniques such as muscle relaxation, breathing exercises, music, mindfulness, and other techniques. Some have also used yoga, massage, and application of warm packs or acupuncture. And whatever choice the woman makes for analgesia in labor should be supported. For women who are laboring in water, the temperature of the woman and the water must be measured hourly to ensure that she's comfortable and that there is no pyrexia. And the temperature of the water at any point must not exceed 37.5 degrees Celsius. Regarding oral intake and fluids in labor, for women who are at low risk, they should be encouraged to take oral fluids and light foods during the process of labor, because it's been found that restriction of oral fluids and food intake has no beneficial effects on any important clinical outcome in these women. Women may eat a light diet in established labor unless she has received opioids, which may cause nausea and vomiting in her, as earlier discussed, or if she develops any risk factors or complications that might make administration of general anesthesia more likely in her. The assessment of her urinary output and the presence or absence of proteinuria can be used to monitor her state of hydration, and if there is any concern, she can be encouraged to take more fluids orally. However, if it is anticipated that this might not be sufficient, intravenous fluids may be administered to these women. As such, routine administration of intravenous fluids for all women in labor is not recommended. Women should also be encouraged to adopt any position of choice, and they should also be encouraged to be mobile during labor. And in many settings, traditional practices of enforcing bed rest for women in labor are common. However, it's been noted that this does not have any beneficial effects on the outcome of women in labor. So these women should be encouraged to support, adopt any position they feel is more comfortable to them, and whatever choice they make should also be supported. Regarding the active management of labor as a package of care for women in labor, this is no longer recommended. It's been noted that it has, even though it has potential benefits in reducing the duration on labor, and if there's a possible reduction in cesarean section rates, it is, however, considered to be highly prescriptive and interventional, so that all these interventions that have been listed earlier are offered to all women, regardless of whether they actually need it or not. And then, so women who would eventually have achieved vaginal delivery without these interventions will still have had these interventions offered to them. It also reduces these women's autonomy and their right to make a decision regarding their care. The use of amniotomy alone, also for prevention of delay in labor, is also no longer recommended, as there has been no clear evidence that the potential benefits outweigh the potential harms. In low-resource settings, especially where there is no routine screening for HIV in the antenatal period and also in labor, early amniotomy may also increase the risk of maternal-to-child transmission of HIV. So the use of early amniotomy with augmentation of labor for prevention of delay in labor is no longer recommended. So the Partograph has been traditionally used for monitoring women of labor, and this is based on cervical dilatation that's anticipated to be at least 1 centimeters per hour as the recommended rate for progress for the slowest primogravida. However, based on the studies that have been done and have been shown earlier, there is insufficient evidence to support the use of the alert line as a classifier to detect women at risk of adverse outcomes in labor, because it's been shown that the cervical dilatation rate of 1 centimeter per hour may be too fast for, unrealistically fast for some of these women. and this may lead to unnecessary interventions to them due to the perception that the labor progress is pathologically slow. However, if these women had been allowed to progress normally in labor, they would have ultimately achieved vaginal delivery. So, however, the Partograph is not to be done away with in total. It can still be used for monitoring labor progression in a research context. And healthcare professionals can also continue to plot cervical dilatation as well as other parameters, because this also helps us to monitor the well-being of the fetus and also the woman during the process of labor. So it can also be a good monitoring tool apart using the other parameters apart from the cervicograph. In healthcare facilities where interventions such as augmentation of labor and cesarean section and also instrumental deliveries cannot be performed, and where women might need referral if they need this kind of care, the Partograph may also still be important in these women, so that at any time any delay in progress of labor is anticipated, then these women can be referred appropriately to healthcare facilities where they can receive such care. And it's recommended that plotting a Partograph for these women should commence from a cervical dilatation of 5 centimeters as opposed to 4 centimeters, which has been previously used. So the second stage of labor is described as the period between full cervical dilatation and the birth of the baby. And it can be divided into two. The passive second stage, which is also known as the propulsive phase, and is the time between full cervical dilatation and before the onset of involuntary expulsive contractions. The second part is the active second stage of labor, which is also known as the expulsive phase, and this is characterized by expulsive contractions. At this point, the woman expresses the urge to bear down, and then there are active maternal contractions, so that contraction of the anterior abdominal wall muscles also help to facilitate descent and vaginal delivery along with the uterine contractions. The duration of second stage of labor in nulliparous women, second stage is not expected to last longer than 3 hours, while in the multiparous woman, this is not expected to last longer than 2 hours. This is irrespective of whether a woman has been on epidural analgesia or not. The exact onset of the second stage of labor cannot be appropriately determined because one might not appropriately know the time in which a woman attained full cervical dilatation. Also, some women may feel or express the urge to bear down before the cervix is fully dilated. And at the point there is a full cervical dilatation, she may not yet express this urge. So at church, it might be difficult to know the exact timing of the onset of second stage of labor. There are studies that have been done in order to assess the mean duration of second stage of labor in these women. And this is a study that was done by Abalos et al. In nulliparous women, it was found that the median duration of the second stage of labor ranged between 14 and 66 minutes, with 95th centile values of up to 138 minutes. In women who also had epidural analgesia, this was found to last longer and lasted up to 3.6 hours. And while in multiparous women, the median duration was within 6 to 12 minutes, and in those who also had epidural analgesia, the 95th centile values were up to 120 minutes. So in a woman who is now in the second stage of labor, one needs to assess her progress in labor in order to determine if and when she needs any intervention. So in a nulliparous woman, if there has been inadequate progress in labor, described by progress in rotation and or descent of the fetal presenting parts, and if there has been no progress or inadequate progress after 1 hour of active second stage of labor, then one can suspect delay. While in a multiparous patient, if this has been inadequate after 30 minutes of active second stage, then one can suspect delay in labor at this stage. So if this has been determined, then one can offer interventions. This woman should be reviewed holistically. A vaginal examination should be done in order to assess the state of caput and molding, which may suggest cephalopelvic disproportion. If the membranes are still intact at this point, then amniotomy should be offered to this woman in order to possibly hasten vaginal delivery. However, when there has been no or inadequate progress within 2 hours in a nulliparous woman or after 1 hour in a multiparous woman, then delay in labor is confirmed. And this woman, if she's in a facility in which there is no availability of a senior obstetrician to review this patient, then referral of this patient to a more skilled center can be undertaken. And as such, at this point, patients can be considered for instrumental vaginal delivery or cesarean section if needed. Consideration may also be given to the use of oxytocin with these women, especially if they are already on analgesia, especially for nulliparous women, if the contractions are noted to be inadequate in order to facilitate vaginal delivery. So regarding the birth positions that women adopt during in second stage of labor now for delivery, traditionally supine position has been used for women. However, it has been found that some adverse effects may be associated with this supine position, and this includes the possibility of supine hypotension syndrome in these women, which may be associated with more frequent fetal heart rate decelerations. So in order to prevent this, women should be encouraged to adopt a position of a birth position of choice, and upright positions may also be included in this. And some of these positions include the sitting position, squatting, kneeling, semi-recumbent position, and whatever position the woman chooses should be supported. However, any position that may prevent adequate fetal monitoring should be communicated to this woman, and as such, a birth position should be chosen between both the woman and the healthcare provider in order to facilitate smooth labor and delivery. So there's a concept of delayed pushing, and this is based on the theory that allowing a woman a rest period in the second stage of labor allows the fetus to passively rotate and descend while conserving the woman's energy for pushing efforts. So this means that once a woman has been diagnosed to be in the second stage of labor, a period of about 1 hour can be allowed for this woman, during which she is not actively pushing, and this will allow a time for passive descent of the fetus. And this is currently still recommended by the World Health Organization, and this is proposed to allow the woman to rest and conserve her energy for the period of active pushing. It's been found to extend the duration of second stage of labor by approximately 1 hour, and is associated with approximately less 20 minutes of active maternal pushing efforts. So this could prevent exhaustion in these women. There have, however, recently been some studies that have been done to assess the efficacy of immediate versus delayed pushing in women on epidural analgesia in the second stage of labor. And it was found that delayed pushing, in women who had immediate pushing or delayed pushing, there were actually no differences between the rates of spontaneous vaginal births. Women who had immediate pushing had a shorter average of duration of labor by about 32 minutes. However, the duration of active pushing was longer for about 9 minutes than women in the delayed pushing group. Women who also had immediate pushing had lower rates of complications such as chorioamnionitis and postpartum hemorrhage, and the neonates had lower risk of acidemia than those who had delayed pushing. So as such, currently the American College of Obstetricians and Gynecologists propose immediate pushing at the second stage of labor for nulliparous women receiving epidural analgesia. So in preventing perineal trauma and administration of episiotomy in women in the second stage of labor, there are different techniques that have been proposed in order to prevent perineal trauma, perineal lacerations, and such as the hands-on approach, which involves active guarding of the perineum and flexing the baby's head. Or there is also the hands poised approach, in which the hands are kept off the perineum and the baby's head, but in readiness, so that if any intervention is needed, it can be promptly applied, and this can be used to facilitate vaginal birth. There are other techniques such as perineal massage and warm compresses, which may be given to women based on their preferences and if she requests it. However, these have not been found to reduce the incidence of perineal trauma or the need for episiotomy in women undergoing labor. Episiotomy should only be administered once there is a clinical need, and before episiotomy is administered, the woman must be informed about what the procedure is about, and consent must be obtained for this woman before episiotomy is administered. The routine use of episiotomy or liberal use of episiotomy is not recommended for women undergoing spontaneous vaginal birth because it's not been found to reduce the incidence of perineal trauma or to increase the rate of vaginal delivery in these women. Before episiotomy is administered, one must ensure appropriate and effective analgesia for these women in order to prevent pain. So the recommended technique for episiotomy is the administration of a mediolateral episiotomy, which is one that originates from the vaginal fourchette and is usually directed towards the right side at an angle of between 45 and 60 degrees to the vertical axis. And this has been found to have better outcome than other types of episiotomy. In repairing episiotomy, it is recommended now that the repair should be done using a continuous suturing technique as opposed to an interrupted stitches, as this has been found to be associated with less need for analgesia and with less pain in these women. Routinely, women should not be administered prophylactic antibiotics after a spontaneous vaginal delivery. Administration of episiotomy also do not warrant the routine use of prophylactic antibiotics, as general aseptic techniques must be ensured in these women at all times. So the third stage of labor now describes the time from the birth of the baby to the expulsion of the placenta and membranes, and this is the time immediately after the birth of the baby. Any care or interventions administered at this point are sensitive and should be done in order to, in a way in which to minimize disruption or separation of the mother and the baby. The third stage of labor, active management of the third stage of labor is recommended, and if using the active management of the third stage of labor, the placenta has not been delivered within 30 minutes of birth, and then one can say there is a prolonged stage of labor, or also known as a retained placenta. However, when the physiologic management is employed, that means that when there is no intervention and the placenta is allowed to be delivered spontaneously, one anticipates that this should occur within 60 minutes. And if after 60 minutes of delivery of the baby, the placenta has still not been delivered, then a diagnosis of a retained placenta can be made. The active management of labor contains 3 active components, and this involves administration of oxytocin, which recommended is parenteral oxytocin, administered either intravenously or intramuscularly within 60 seconds of delivery of the baby. And this has been found to be the most important component of the active management of labor, as it reduces the amount of blood loss in women following delivery. Then controlled contraction for delivery of the placenta is also advocated, and this also helps to achieve quick delivery of the placenta with minimal complications such as uterine inversion and retained placenta in these women. Then after this has been achieved, postpartum vigilance, which involves assessment of uterine tone to ensure that the uterus is well contracted, should be done every 15 minutes for the first 2 hours following delivery. So these are the components of active management of labor. Delayed clamping is also recently encouraged in following delivery of low-risk women, and this involves delaying clamping of the umbilical cord for at least 1 to 3 minutes after delivery, and this helps to improve maternal and fetal health nutrition because there is increased transfer of blood to the fetus. This reduces the amount of or the rate of neonatal anemia in these babies. However, in babies who are delivered asphyxiated or who need immediate resuscitation, then this cannot be applied, as the cord must be clamped immediately in order to allow for prompt and adequate neonatal resuscitation. So following delivery, there are some important things to note in immediate assessment and care of the newborn. In neonates who are born through clear amniotic fluid and who achieve spontaneous respiration after birth, the suctioning of the mouth and nose should not be performed, as this is unnecessary in these babies and is not associated with any improved outcomes in them. In the presence of any degree of meconium, these babies, and in the presence of any degree of meconium, once the baby has been able to achieve and sustain spontaneous respiration, and the heart rate and the fetal tone and the neonatal tone are good enough, then these babies do not need suctioning. However, if the respiration is abnormal or the baby has not been able to achieve spontaneous respiration, or if there are other signs noted such as bradycardia, or if the tone is reduced, then early laryngoscopy and suctioning under direct vision is advocated for these babies rather than blind suctioning. So babies who don't have any complications must be kept in skin-to-skin contact with their mothers as soon as possible following delivery, and this must be established during the first hour after birth. And this helps to promote bonding between the mother and the baby. Also helps with early initiation of breastfeeding in these women, and it also helps to prevent hypothermia in these babies. So breastfeeding must be initiated as soon as possible within 30 minutes to 1 hour following delivery. And all newborns should be administered 1 milligram of vitamin K intramuscularly in order to prevent hemorrhagic disease of the newborn in these babies. If possible, bathing of these babies should be delayed until at least 24 hours after birth, and the baby should be appropriately clothed and ambient temperature ensured in order to prevent hypothermia in these babies. Following delivery, the women should be monitored closely as discussed, especially within the first 2 hours after delivery. And following this, they should also have regular assessment of for presence of vaginal bleeding, which is in excess of what may be expected for normal look-here. The uterine contraction will also be assessed, and the uterus should be tonically contracted. The one will also want to ensure frequent assessment of the fundal height with woman's temperature, blood pressure, and fetal heart rate during the first 24 hours following delivery. And one should also ensure that this woman voids her bladder within 6 hours, and this should be documented. Routine antibiotic prophylaxis is also not recommended for women who have had a spontaneous vaginal delivery, which was uncomplicated. And following appropriate monitoring of these women at least 24 hours following delivery, if there are no complications, then these women can be discharged home. So women who delivered at home must be encouraged to present in a healthcare facility within 24 hours for assessment of both they and their babies. And it's now recommended that at least 3 additional postnatal contacts should be advocated for women and their newborns. And this should be done within 48 to 72 hours of delivery, between 7 to 10 days, and at 6 weeks postnatal clinic visits for these women. So some of the recommendations from this presentation include advocacy and government commitment to increasing coverage of maternity care for all pregnant women, as the need for this cannot be overemphasized. Women have a right to be attended to during the antenatal period and during the process of labor and delivery by a skilled birth attendant. Then labor monitoring tools should also be standardized, and then this will include a revised Partograph, as the current WHO Partograph in use does not reflect all these recent changes and updates that have been proposed in the management of labor. Sensitization on respectful maternity care for all health workers is also important, as it is a fundamental human right of pregnant women and babies in these facilities to be treated with respect and dignity during the process of labor and delivery. Healthcare providers will need training and retraining in order to keep them abreast of these constantly evolving changes in the management of women in labor. And for each healthcare facility, there should be a written departmental protocol on labor management and constant drills in training these healthcare providers so they know what to do and how to take decisions at every time in labor. So in conclusion, labor is a dynamic and life-changing event for every pregnant woman and her family. And as we can see, the management of labor is constantly evolving. Healthcare providers at all times must keep abreast of available information and recommendations in order to provide pregnant women with the best care that they need and ensure that they indeed have a positive pregnancy experience. Thank you for listening.